It's going now. All right, welcome everybody. Today's topic, we are talking about paraneoplastic syndromes. Can everyone hear me all right?
Yeah.
Okay, cool.
Yes.
There's been intruders in my office. You can see one behind me. And everything on my desk has moved, so I'm not sure where the microphone is. Oh God. We're talking about paraneoplastic syndromes, and now all of a sudden I'm feeling really self-conscious and out of my depth because Penny Thomas has joined us today, who is an oncologist. But I'm really excited to be brought up to date with anything that I'm falling behind on. But I do like talking about paraneoplastic syndromes because it's so clinical. You're presented with a patient with this symptom, and could it be attributed to neoplasia, and what is the mechanism behind that? So this is a topic that I quite like to talk about, and is one that we deal with really commonly clinically, probably before they get to Penny, usually, I would imagine. And other nice thing, which we can get Penny to weigh in on, Penny doesn't know I'm throwing her under the bus with any of this. But
never come back. This.
Sorry, you're never coming back.
I will never come back.
It's the last onco. I can do no wrong.
Good. Yeah.
So a lot of the time, these paraneoplastic syndromes, like the degree of anemia, the degree of hypercalcaemia, things are actually prognostic indicators. So as we talk about them, we might sort of go into what diseases cause those paraneoplastic syndromes, and whether they have any bearing on the potential outcomes, and whether it's worth pursuing treatment in certain patients. So let's just throw it out there. What sort of broad categories of paraneoplastic syndromes do we see?
Hormonal.
Hormone, good. Endocrine, excellent. Good.
Gastrointestinal.
Good.
Sometimes neuro as well.
Yeah, excellent.
Lameness, orthopedic.
Ooh, very good and specific. Renal, good.
Hematopoietic as well.
That's a big one. Yeah. And I'm going to actually broaden that out to hematologic, because it's not all poiesis. It's sometimes other mechanisms.
Yeah, that's a good point.
Yeah. But yes, you're completely right. And there's one more, which is kind of one of those ones that we ignore as internal medicine specialists, because we don't see them very often. What was that?
Is it cutaneous?
Yes, exactly. Yeah. Ignore.
Yeah, fair enough.
Yeah. So does anybody have any strong preferences that they want to talk about a specific presentation, and they've got a case that they're kind of interested in how that blood change or something change correlated with a neoplastic disease?
Well, an interesting one is that cat you saw for me at Hornsby. I just happened to notice on about 2 or 3 previous profiles its potassium was up a bit.
Mm-hmm.
And I thought, oh, well, that's interesting. We'll get Anna to ultrasound that. And she found quite a large adrenal tumour.
Oh, it was low. The potassium was low in that one.
Oh, low, sorry.
Yeah.
Yeah, and I noticed that over about 2 or 3 profiles. And otherwise, it was just quite a mysterious disease to everybody. And I think it was about a 5-centimetre tumour, wasn't it?
It's huge. Yeah, absolutely huge. It was almost as big as the cat's abdomen.
And it's doing well, incidentally.
Good. On just medical management?
Yes.
Excellent. That is good. Are you supplementing potassium and spironolactone, or just spironolactone?
I think just spironolactone. I'm not sure, actually. I haven't. It's a long time since I've seen it now.
Excellent. Good. So we've talked about an adrenal tumour causing hypokalemia. What's the diagnosis?
Addison's? Hypo or hyper?
Hypo.
Yeah. Oh, Addison's?
It's actually tell me how, which hormones are deficient in Addison's?
Well, it'd be corticoids and plus or minus,
Mineralocorticoid.
sometimes aldosterone, mineral corticoids.
Yeah. So aldosterone, which is or aldosterone, I don't know how you pronounce it. Aldosterone is what I usually say.
Depends whether you're trained, whether you're an American or not.
Yeah, exactly. Depends which podcast I've been listening to. So aldosterone is the mineralocorticoid that's produced in the adrenal cortex. What does that hormone do?
Volume status, potassium. It regulates potassium in the body.
Yes. If you have an excess of aldosterone, will you have high or low potassium?
Well, we've already told them.
No.
Low. 50-50.
Yes.
Yeah.
Like
You know it. Like if you sort of sat down and thought about it, and I wasn't putting you on the spot on a Zoom call, you'd know you've got your Addisonian dogs who have a deficiency in aldosterone, and they present with high or low potassium. High.
Right.
So deficiency in aldosterone causes high potassium, excess aldosterone or low potassium. So Jeff's case is a cat that has an aldosterone secreting tumor. So
Is that Con syndrome?
Con syndrome, exactly. Yeah. And it has, as a result, hypocalcaemia and the symptoms that go along with that. That's a really specific one. There's not that many cancers, I think, that would cause. No. I mean, yeah. So that's one blood change. Any other sort of cases or presentations people want to talk about?
Hypoglycemia in a patient with potential insulinoma.
Good. Yeah. And we talked about this a little bit in the did we talk about this in the insulinoma endocrine section? We must have. Hypoglycemia. So say you have a patient that presents to you just a bit lethargic, a little bit off, and you do some blood tests and you see mild hypoglycemia, but there's no sort of neurological changes or specific muscle weakness or anything associated with that. What are your differentials for that?
I guess, insulinoma or other, it could also be paraneoplastic in other ways. It could also be something like a xylitol toxicity.
Good.
Those kind of things.
Yeah.
I think you can also, I remember Edger, I think it's in there as things like Fanconi or glucose released through the kidneys. You can get reported hypoglycemia. I think it's quite rare.
Yeah.
Yeah, you get urine sugar, but not usually blood sugar changes. I think. The one case I've seen was like that.
Yeah.
Also, working dog hypoglycemia, which the Americans call hunting dog hypoglycemia.
Yeah.
Addison's.
Yeah. Very good. Yeah. So that's
young dogs.
Sorry, say again, Josh.
So, and also if it's a young animal.
Very young, exactly. So neonates that just don't have that glycogen storage.
Hepatic failure.
So Josh mentioned other paraneoplastic manifestations or causes of hypoglycemia. That was very vague. Can you be more specific?
I can be more specific. I think so. You can get insulin-like secreting tumors as well, which act similarly. You can get, I think, increased insulin receptors as well. So they take more glucose into cells. You can also get, I think some cancers will consume glucose more, so you can get a consumptive loss.
Cool.
And I think there's like other weird ones, like I think multiple myeloma maybe is related somehow, but I don't know how. I can't remember.
Penny.
Liver tumors, like
Yeah.
really.
Oh yeah. Look.
Oh yes, yeah.
You can definitely see a hypoglycemia with those.
Why?
Do you want me to answer that, or did you want to answer
Well,
that?
no, I don't know the answer, so therefore I feel mean asking other people.
We don't entirely know why, but we think it's to do with impaired like gluconeogenesis and these tumors not being able to store but then re-release glucose as normal liver parenchyma can. And if you've got really big or diffuse disease and you don't have a lot of normal liver left, you quite often don't see it in isolation. Like you quite often will see other changes related to hepatic failure, but with a big liver tumor.
Okay. So it's not, so it's more a kind of lack of functional liver parenchyma.
Yeah, it's not, I suppose it's not technically paraneoplastic, but it's something that you do see as a like related to a cancer being present. It's not like the cancer's secreting insulin or anything like that. It's just there's not a lot of functional tissue left because of the cancer.
Yeah. You know, you see like a case that really sort of changes your like impression of how common things are, or like so Penny and I actually co-managed a case many years ago of leiomyosarcoma. And this dog had mets everywhere. It had been originally a bladder tumor and it was just splenic, liver, lungs everywhere. And the dog's main presentation was hypoglycemia. So I always put leiomyosarcomas on the list, but I'm not really sure why or what mechanism. Is it just consumption?
I think it's just consumption. I think it's just like sheer volume of disease, right?
Because they're muscles, they're very metabolically active.
Yeah.
Interesting. Excellent. So the ones that I've got listed, insulinoma, which we've talked about quite extensively, and I am getting confused because I did an insulinoma podcast. So I might not have talked about it with you guys, but if you want to talk about insulinoma more specifically, happy to.
I have a question.
Yeah, go.
With insulinoma, would the degree of change matter? Like, for example, like just mild hypoglycemia, less likely to be insulinoma because you have to have severe hypoglycemia. Like, can you say that or not really?
I don't think so. And it's also, it can be variable. Like it's not going to be you're consistently sitting at 1.2 for your blood glucose. It definitely can fluctuate because the tumor can fluctuate by how much insulin it does or doesn't release. But the degree of hypoglycemia, I don't think is always proportionate to like how bad the disease is or whether or not it's present, because you can definitely see some patients who have like stage 3 disease, mets everywhere, it's all functional, but their hypoglycemia is only very mild. Usually not, like usually it's quite severe and they're clinical for it, but it's a really fascinating disease. Like a tiny tumor can have such a huge impact, and a huge amount of disease, it can be very mild. So it's really variable.
Thank you.
Is the presentation of being symptomatic for hypoglycemia predictive of a poorer outcome at all?
It's interesting. I feel like we don't have a study that specifically says that, but often when you have patients who are presenting symptomatic, they are a little bit harder to manage medically, at least initially. And a lot of owners, once they then get a diagnosis of, okay, this is cancer, they're already like, well, my dog's already sick. Like, why would I do anything more? So whether there's that sort of confounding factor of early owner preferred euthanasia because they're clinical, we just don't know.
Yeah, that does confound things. So back to Pooja's question about the variability of the glucose, from a sort of clinician's perspective, I find this really interesting because quite often a dog develops neurological symptoms at home and because of their hypoglycemia, so they'll start either tremoring, facial twitching, or full-blown seizures, and then the glucose dipping low enough to develop symptoms creates this counter-regulatory response, the hormone response. Can you tell me 4 hormones, in fact, can you tell me 2 hormones which will increase glucose in hypoglycemia in an acute hypoglycemic crisis?
Cortisol
Yes.
will cause insulin resistance.
Good. Yeah. And there's one more hormone that will help push the glucose up.
Adrenaline.
Adrenaline, exactly. Yeah. So they're the 2 acute phase hypoglycemic crisis hormones. So you have a dog that gets really hypo at home, starts seizuring. By the time it comes into you, it's stopped seizuring and its glucose is normal. So we miss these. So on average, I think with insulinomas, dogs have been symptomatic in hindsight for around about 3 months before they're diagnosed, because they're not always hypoglycemic. There's a lot of fluctuation. So these are ones that we I don't know how we do it, but it would be really nice to do a fructosamine in every single seizuring dog and see if it's low. I don't know what the sensitivity of that would be, but or put a sensor on them and see what's happening throughout the day long term if there's been a couple of little neuro episodes like this. So yes, good question, Pooja. There's 2 other hormones that then in a more chronic hypoglycemic event will kick in. Does anyone know what they are?
Glucagon. And
Should have mentioned glucagon in the acute phase as well. Sorry. Cortisol is more like a chronic one.
And growth hormone.
Good. Yeah, excellent. So cortisol causes insulin resistance, but it does take a little while for that effect to happen. And then the other effect it has is to help store more glucose in the liver. So you've got more glycogen storage. You're ready for a hypoglycemic event if you've got more cortisol. So it does help both in the acute setting and in the chronic setting. And then growth hormone does heaps of stuff that helps with decreasing the effect of insulin peripherally, I believe. Okay, what other presentations do we see on blood tests?
cytopenias.
Good. Let's talk about one cytopenia. Which one do you want to talk about?
I mean, with estrogen secreting tumors, you see like PAN sometimes.
PAN, yeah, I like that. Yeah, I was too specific. Good. When do we see hyperestrogenemia?
Sertoli cells. Tumor.
Excellent. I wrote down something about this that I found interesting, but I've forgotten it immediately. Do you know what percentage of dogs with a Sertoli cell tumor will exhibit symptoms of hyperestrogenemia?
It's like a third.
Oh, that's a really hard question. I'm so impressed. Yeah, 30 to 50, but it's not all of them. So if you see a testicular tumor or an intra-abdominal tumor in a cryptorchid dog, don't rule out Sertoli cell or hyperestrogenism in those patients. What other symptoms other than pancytopenias?
For this specific tumor or general?
Or hyperestrogenism, just as far as like the whole picture and presentation. If you've got a pancytopenia and this and that, then you've got a pretty good idea of what's going on.
Yeah, cutaneous changes as well. I think like hair loss, like symmetric alopecia, that kind of thing.
Excellent. Yeah.
Feminizing of a male dog.
Yeah, gynecomastia.
Yeah, excellent. And atrophy of the contralateral testicle if it's palpable or ultrasonographically visible. They also get this really distinct prepucial erythematous line that goes down the ventral aspect of their prepuce, which apparently is quite pathognomonic for Sertoli cell tumors. And I've only seen it once and it was after I'd been to a derm talk randomly. And she said, if you see this, this is what this is. And I saw it with you. Did you?
Yeah, I think I was there. We had this case that was a dog that was very sick, pancytopenic, I think, but had this prepucial line, and in its history it was a cryptorchid.
Oh. And
we were hunting for a tumor, but I don't think we found one in the end, unfortunately. I think they wouldn't do a CT or something, but that was the theory we had.
It was there for sure. Excellent. All right. So pancytopenias, what other tumors would we see pancytopenias with?
Like bone marrow disease, so metastatic bone marrow disease, or primary like leukemias, those kind of things, lymphomas. Yeah.
Now, I should have done this at the beginning, but what's the definition of a paraneoplastic syndrome?
Is it? I'll let someone answer who actually might know the right answer instead of guessing.
are a group of systemic disorders that result from the systemic or metabolic effects on tissues remote from the tumor.
Good. Yeah, excellent. So my question is now, and I don't know the answer, Penny, is a pancytopenia from an infiltrative bone marrow tumor? Like say we've got, you know, one of those bone marrow tumors.
Something.
Beg your pardon?
Multiple myeloma.
Yes, let's say that. So say we've got a pancytopenia. Is that a paraneoplastic syndrome?
See, I don't think technically it is.
I don't think so either.
No.
So if you've got anemia arising from the tumor causing a neuropathy or a hepatopathy, then that's a paraneoplastic syndrome. But because this arises in the bone marrow and that's where the disease is, then it's technically not a paraneoplastic syndrome.
It's
That's
just a
semantics.
symptom related to that cancer.
Yeah. So we won't talk anymore about pancytopenias. What about individual cytopenias?
Anemia of chronic disease.
Great. Yeah. I think that's probably the most common one that we see. Dogs just coming in a bit slow and you do bloods and it's just got a mild anemia. Can you characterize what the anemia usually looks like in these anemia of chronic diseases? Like it's mild. Is it hypochromic, normochromic, macrocytic, microcytic, normocytic?
I think it's normochromic, normocytic,
Great.
and regenerative anemia. Is that right?
What was the last bit?
Is it non-regenerative or regenerative?
Yeah, almost always non-regenerative. Yeah, exactly. That's exactly right. So it's that anemia that you look at and just go, there are no clues here as to what's causing this. Everything is normal apart from that number. So that usually that's an indication that there's been some systemic inflammation chronically, or chronic illness going on. So that causes a few different effects. That arises from a few different effects on the red blood cells of chronic inflammatory disease. Can anybody tell me why we actually get an anemia with chronic inflammatory disease?
Is it like oxidative injury?
Yes. So decreased red cell survival. Excellent.
It's also to do with hepcidin, like inflammation will cause release of hepcidin, and that then affects the transport and iron sequestration or something.
Yes, exactly. So iron metabolism is off in quite a few ways, like absorption changes, other stuff happens. Hepcidin rings the bell.
Sequestration, I think, sequestration of the iron, it doesn't go to the tissue, something like that.
Yes, yeah. Good. You know more about this than me officially. I remember reading a paper on this. There's a good paper on anemia of chronic disease and the iron metabolism changes that occurs with that, which I no longer need to know, but Josh does. So we'll get him to research that.
Yeah.
You know that one?
No, but I want to read it.
Oh, I'm sure you do.
So those, it's not microcytic or hypochromic because there's also the oxidative damage. It's just less apparent than it's iron deficiency anemia.
Yeah. So we've got this combination of destruction, which should cause regeneration, but also this change in iron metabolism, which means that regeneration isn't really possible. So it's kind of an effective iron deficiency, but actually they measure normal if you measure their iron. What other causes of anemia might we see as a paraneoplastic syndrome?
I was wondering, going back to the definition, but things like microangiopathic anemias,
good,
or like hemolysis secondary to things like histiocytic disease, would that be paraneoplastic, or would that be just the cancer doing its thing?
I think it's paraneoplastic.
Okay.
Yeah, because it's the cancer affecting something distant from itself.
Yeah.
So and it happens to be that the red cells get damaged on the way through.
I suppose maybe the only exception to that would be those like hemophagocytic histiocytic sarcomas that you see like primarily in the spleen, where like it's actually the cancer that is causing like direct red cell destruction there. But like they happen really rarely.
So we then kind of like, as far as like categories in my head, causes of anemia with disease, we're talking about IMHA here, immune mediated hemolytic anemia. And there's two different kind of mechanisms that can happen. So what Penny just mentioned then, has anybody heard of hemophagocytic syndrome? It's a really interesting manifestation of histiocytic sarcoma. So the histiocytes, which are like macrophages essentially, in the spleen become neoplastic, and they just start munching on all the red cells inappropriately. So that is technically an immune-mediated hemolytic anemia, because the immune cells are inappropriately hemolyzing the red cells. So that's why what Penny was saying, that's not a paraneoplastic syndrome, that is just a neoplastic syndrome kind of thing. But then the other mechanism is of IMHA in neoplasia. Does somebody tell me?
Antibody production.
Good. Yeah. Why would the immune system all of a sudden, in the face of cancer, start producing antibodies against red cells?
I mean, the immune system is going to be trying to remove that. Well, I guess in some ways, trying to remove that cancer, but so maybe that's where the immune stimulation is coming from, and then there's an inappropriate target.
Yeah, so I think that's a really reasonable response. So essentially, anytime you've got immune stimulation, anytime you've got the immune system responding to novel antigens, which we would with neoplasia, we've got that molecular mimicry risk arising. So if there's and in addition to that, the normal kind of checkpoints in the immune system might be dysregulated by immune cell cancers, so lymphoma. So you might then get a lot of antibodies produced to self-antigen, where normally that would have been kind of, that cell would have been taken out of circulation. Excellent.
Would hemorrhage from something like a hemangiosarcoma, that's just going to be primary neoplastic as well, I'm assuming, right?
It is. Can you think of, it's kind of in a different system, but a cause of hemorrhage that might be paraneoplastic due to the tumour's effects on a different system?
Like a thrombocytopenia, or?
Oh, that's a good call, maybe. That's a good...
hepatic failure.
Histamine release from muscle tumor causing gastric ulceration and bleeding.
So that is a paraneoplastic cause of anemia by hemorrhage. Yeah, very good. So what are there's mast cells that will cause gastric ulceration by increased histamine release. There's another tumor that can cause gastric ulceration. It's rare.
Gastrinoma.
Good. Drop the mic. That's very impressive. Excellent. So they're the two main causes of gastrointestinal effects, paraneoplastic effects, essentially, and they both cause ulceration and hemorrhage. And then we also get like random GIT effects, like not eating as much and stuff. So that's boring. All right. What about tumors that cause changes on we've sort of talked about pancytopenias, but what about thrombocytopenia specifically? Any tumors that will cause thrombocytopenia?
Leukemias, but again, I'm not sure if that's paraneoplastic or neoplastic.
Yeah, so we've got decreased production as one of the mechanisms.
things like hemangiosarcomas you can get from cytopenia, consumption.
Good. Yeah. Excellent.
Probably autoimmune destruction as well, IMTP.
Exactly. Yeah. So same as with, I didn't really kind of spell this out with the anemia. If you think about it in mechanism, so decreased production, increased destruction, or sequestration, you know what I mean? They're good sort of kind of ballparks to have in your head, and then like put little sub differentials under there. Okay, what about thrombocytosis? Do we ever see thrombocytosis associated with neoplasia?
Yes.
Yes. Yeah.
Primavera, whatever it's called. The primary polycythemia, isn't that what you're getting?
Oh, that's erythrocytosis. Is that what I said?
Oh, did you? Sorry, that's what I.
Thrombocytosis. Yeah.
I said thrombocytosis.
Sorry. I had erythrocytosis in my head. Oh.
You could get a leukemia, like a cancer of the platelet producing cells, couldn't you? The megakaryocytes.
Sure, you could, but I've never heard of one.
You do. They're really, really rare.
Yeah.
That was a theoretical comment, not a.
Yeah. So
So it's definitely possible they exist. They're very uncommon.
Yeah. What treatment do we often give to patients with cancer which causes a thrombocytosis?
Prednisolone.
Oh, good one. Yeah. Another one.
And Christine.
Good. Excellent. So there was a stat quoted in Edinger chapter that said 30 to 50%, no, it wasn't 30 to 50, it was like most dogs and cats with thrombocytosis have neoplasia. And it was like the percentage was like over 50. But they didn't then like classify whether these were patients on treatment or not, because that's not something that I've really observed. I'm interested in Penny's perspective on that.
I see thrombocytosis not infrequently either as a like pre-treatment thing or as a result of treatment, definitely. And for the most part, it's like, okay, it's there, it's fine. We're not going to do anything about it.
Yeah.
But I feel like I see it most commonly in dogs with nasal tumours, which I can't easily explain. But then also we do see it in dogs with hemangiosarcoma as well. Okay. Almost like they lost a whole heap of platelets, and then you remove their bleeding splenic mass, and all of a sudden they've got a heap. So whether it's like a rebound thing, or something like that, like their bone marrow was trying really hard to replace all the platelets, but they just kept bleeding from their tumours until you took the bleeding tumour out.
That makes sense.
Yeah.
It's reported with bronchial carcinoma and osteosarc as well, as a paraneoplastic thing. But I have to say I don't deal with a lot of, and also I don't really notice it because it doesn't have a clinical relevance really. But it's an interesting thing. If there's thrombocytosis, put cancer on your list, on your bloods. All right. I want to talk about hyperglobulinemia. Does anybody else?
Yeah.
Yeah. What can, how would your patient with hyperglobulinemia present typically?
Have like nosebleeds or like hyperviscosity syndromes.
Good. Yeah. What so hemorrhagic manifestations of hyperglobulinemia, do you know what the mechanisms are?
It's like I think it's a hyperviscosity syndrome, isn't it? Just like hypertensive hyperviscosity syndrome.
Ooh, separate. So I think of hemorrhagic and hyperviscosity as separate. I'm not sure what all the mechanisms are, but definitely one of them is that the antibodies coat the surface of the platelets and stop the platelets from binding and activating. You know, the platelets have to be able to like contact the collagen to be activated, and then all of the sequelae from there happen. So the platelets are less sticky when there's hyperglobulinemia, so less likely to be activated. So they can get like often present like a thrombocytopenic dog, but with a normal platelet count. So often bleeding from the gums, nosebleeds that you mentioned, and little petechiae and bruising easily on the skin, but usually not catastrophic like cavitary bleeds and stuff. So then hyperviscosity syndrome, what other organs affected by hyperviscosity?
The eye.
The eye. Yeah, excellent. What will clinical presentation be?
You know, I just can't remember. I think whether it's hemorrhage, like retinal hemorrhage.
Yeah.
I can't remember.
It can be, yeah. So they get really like thickened, tortuous vessels in the back of the eye, and they can rupture more easily. And I have just written down retinopathy because there's a few different mechanisms of that. One of them is that the blood is so thick that the retina is not being perfused properly. And that can also cause a retinopathy.
Hyperviscosity syndrome cause CVA, like cerebral vascular accidents?
Yeah. Yes, definitely can. And also just hypoperfusion. So sometimes they can just come in with a big sort of personality change and dull behavior and decreased interaction and stuff. So definitely neuro manifestations. So we've got ocular and neuro.
Including seizures?
It can be seizuring for sure. Yeah. It's pretty severe when they're seizuring. What other organs in the body has very small vessels that rely on good viscous blood? I mean, non-viscous blood.
Kidney.
Good.
Kidneys.
Yes. Yeah. Excellent. So renal perfusion is not going to be great in these patients. So that's most of them. What is the most common cause of hypoglobulinemia?
Multiple myeloma.
Good. What are the other causes of hypoglobulinemia?
I think like lymphoma.
Inflammation.
Good. Chronic inflammation. Excellent.
In a cat,
Say again.
in a cat, it's FIP.
Oh, yeah, good. Exactly. Yeah. How are you going to differentiate these differentials?
Protein electrophoresis.
Good.
So if it's a monoclonal or polyclonal gammopathy, that kind of thing.
Yep.
Sorry, monoclonal gammopathy.
Yep. And if it's inflammation, what's it more likely to be? Monoclonal, polyclonal?
Polyclonal.
Excellent. Anything else we should cover or know about multiple myeloma? Yes.
Bone.
Good.
Bone problems.
Yes. So practically, I mean, the protein electrophoresis is exactly what that's the result you want, but it's often delayed, and you've got this patient in front of you that's like maybe presented acutely lame or quite unwell, potentially seizuring, or you almost need results a little bit faster. So if I'm thinking it's most likely multiple myeloma, but I want to rule out other stuff, I'm going to want to get all of the tests done so that I've got all the results I need to have a diagnosis by the time that protein electrophoresis comes in. Ideal world, obviously, not all clients can do that, and not all patients need that urgency. So Jeff mentioned bone stuff. What other tests should we do if we're trying to prove multiple myeloma?
Urine, check for Bence-Jones.
Great. Excellent.
Bence-Jones protein.
Yep. What's the bone stuff?
Oh, what's the word? The thinning of it. Dear, my brain, it doesn't work much more anyway anymore. But
you came up with bone stuff.
yeah, my sort of moth-eaten.
Good.
What's the word?
Lytic. Yeah.
Type picture.
Yeah. Perfect. And where do we normally see those lesions?
I was thinking long bones, but
I don't know.
Vertebrae.
The vertebrae as well.
As well, like the spine.
Yeah. So I don't know whether they occur more commonly in long bones and the spinous processes, or whether that's just where we can see them radiographically. Are they just everywhere, Penny, or is there a preferential?
You can definitely see like a generalized like osteopenia, or you can see like these really obvious moth-eaten lytic lesions. But I think what you said is right. We can see them much easier in those dorsal spinous processes, in the ribs, and sometimes in things like the pelvis, but they can occur anywhere. And they do look very different to like our osteosarcoma lesions, and they don't tend to occur in the same like common predilection sites. But they can fracture too. And I've had more than one patient come in with like a pathologic fracture, and you can see the lytic bone lesion there, but it's not osteosarcoma, even though it's in a limb.
Yeah. And is that, are they often in isolation? There's sort of a big one that's fractured and then there's no other lytic lesions, or if you went back and looked, you'd see them?
Usually others. Yeah.
Okay. And how would we go about sampling? Say we had a lytic lesion, no fracture, a lytic lesion that we could see on our radiographs. What are our options for documenting what the cause of that lytic lesion is?
You also have to have osteomyelitis on the list.
Yeah.
Yeah, like some sort of mycotic osteomyelitis.
We've got a hypoglycaemia and a lytic lesion in the bone, could easily be chronic bone infection for sure. Which should be on
bone marrow biopsy as well.
Yeah, so bone marrow biopsy is a good option to demonstrate excess plasma cells in there, and that will add to your kind of diagnostic picture of multiple myeloma. But these lytic lesions in bone, ultrasound guided aspirate of them is actually quite sensitive for differentiation between osteosarc and plasma cell tumours. And if you can document plasma cells in a lytic bone lesion just by ultrasound guided aspirate, very low risk to the patient. It's often inconclusive in my experience, but still worth doing. Penny?
Well, like plasma cells are far more exfoliative than like an osteosarcoma would be, but you can get a diagnosis for either on just fine needle aspirate. You're probably more likely to get a diagnosis if it's multiple myeloma than you are osteosarcoma. And like you said, fairly minimally invasive, much better tolerated than like a jam shitty biopsy, and fairly easy to do quickly, like in a sedated patient. Yeah.
Cool. And I guess that's the other thing. Bone biopsies are going to be slow turnaround time to get results. So if you do feel like that's going to be needed, like there's no bent strand proteinuria, you've got like, you know, your serum electrophoresis pending and only a mild hypoglobulinemia and this lytic bone lesion, then maybe it is worth getting a chunk for culture and like histo, particularly if you're very suspicious of osteomyelitis, like neutrophilia or something like that. I would like to avoid talking about cutaneous manifestations of neoplasia. So let's jump that section and go to neurological manifestations of neoplasia. What might they be?
Myasthenia gravis or gravis, I don't know how to pronounce it, and peripheral neuropathies.
Yeah, good. They're definitely the two that we see most commonly.
And then renal lymphoma causing CNS. I don't really know how and why though. Like, why is it only renal?
I don't know.
It just seems like with renal lymphoma, there's a higher degree of actual CNS involvement of disease. We're not entirely sure why and whether, like, we don't always know which came first, like whether it was CNS lymphoma that just gets to the kidneys. It's generally everywhere though, because it is a systemic disease. But cats with like CNS lymphoma often will have renal involvement and vice versa.
Interesting.
Just depends what they're more clinical for, right? In terms of how sick or not sick they are and how easy they are to treat.
I don't like treating those ones. I'll just throw it out there. They don't seem to go very well.
No.
Okay, so let's talk about myasthenia. What's the mechanism of myasthenia developing in neoplasia, neoplastic diseases? Or what's the mechanism of myasthenia, full stop? Not as a paraneoplastic syndrome. Sorry, that's too hard.
It's also autoimmune. So it's targeting the acetylcholine receptors, I think, on the postsynaptic membrane. the neuromuscular junction.
Excellent.
So, and I think what causes that is it's often associated with thymomas or mediastinal masses, things like thymoma. And again, it's probably some kind of molecular mimicry, I think.
Yeah, excellent. If you diagnosed your patient with myasthenia with a thymoma and you took out the thymoma in its entirety, would the myasthenia get better?
No, apparently no.
Not always. Sometimes, not always.
Never done it. Yeah.
No,
I've never seen it.
a case. There was a German Shepherd who had the thymoma removed and did well afterwards, and then just tanked. Like myasthenia just came back and it just went down in a heap. And I don't think we documented that the thymoma came back. I think just the myasthenia came back. So thymoma, lymphoma is also reported to cause myasthenia. And then there's sort of random cholangiosarcoma as well, which is so rare. What about peripheral neuropathy? When do we see that?
Nerve sheath tumours.
Good. I'm going to a
It's
neoplastic.
Probably not paraneoplastic. Though.
Exactly. Yeah. So more generalized. What would the mechanism of peripheral neuropathy be?
Would that also be similar, like autoimmune again?
Okay.
I don't know
Okay,
how else it would be.
Yeah. So I mean, there's quite a few different ways. So if we talk about it as kind of mechanisms rather than specific differentials. So if we sort of say autoimmune will cause nerve inflammation or what's the word for the coating of the nerve?
Myelin.
Yes. Yeah. So altered conduction through that nerve potentially via inflammatory causes. And then what about a tumor that decreases perfusion to the nerve? Like, what would the mechanism be of nerve damage there? That's a crap question. It's just hypoperfusion. So we could get just nerve degeneration due to decreased nutrient delivery because nerves have an absolute requirement for glucose. So for example, like an insulinoma, where there's been chronic hypoglycemia, we might have a peripheral neuropathy as a metabolic manifestation of a paraneoplastic syndrome. Kind of clutching at straws. Anybody got anything else? Excellent. Okay. You are presented with a 6-year-old cat who is reluctant to walk and over the course of a week seems to be progressively lame with a shifting lameness. On examination, the cat resents palpation of distal forelimbs. How will you approach this case?
Some radiographs.
Radiographs of the
Yeah.
whole cat and the thorax.
Oh, I love that.
Chest as well, for sure.
Yeah, yeah. If you're getting that, firing up that radiograph machine, do the chest too. Good. What am I thinking of? What did I just make you pattern recognize?
Hypertrophic osteodystrophy.
Yeah, also.
HOD. Yeah.
Ooh.
I was thinking of erosive, like cats get this erosive some sort of polyarthropathy erosive. But then that's paraneoplastic though.
So that they can get IMPA for sure, immune-mediated polyarthropathy, absolutely. So that's one of our differentials for sure. It's not the one I was making you pattern recognize though. Josh said
Lung digit syndrome.
Oh yes, also.
That's a good one too.
Yeah. And also not often both legs, is
Yeah,
it?
that is.
Lung digit. It's normally one toe has a tumor
Yeah.
in it. Yeah. What Josh said is wrong, but very close to being right. And 2 words that very similar.
Osteopathy.
Osteopathy, not osteodystrophy. Yeah.
Yeah.
So what is HOD, a hypertrophic osteodystrophy?
That's like the double physis one. I'm thinking of that one. I think of that in like young dogs and stuff. But
Yeah.
Yeah.
Young dogs.
Young
yeah.
dog.
osteopathy is when you get like the growth or like the
Yes.
extra osteoprolific changes.
Good. Exactly. Palisading bone formation down the sides of the, what are these ones?
Metatarsals.
These ones. Yeah.
Isn't HOD now called metaphyseal osteopathy?
Maybe.
Is it?
Yeah, I think so.
That's because it was too confusing with HOD. Oh, which one? Is this one called?
HOD, I think, is now called metaphyseal osteopathy.
Okay. Edinger needs to update. And I actually went off the online version to make sure that I was updated.
Maybe someone double check. I may be wrong, but I think I have in my head.
So I missed what the initiating tumor was.
Okay, so that hypertrophic osteopathy or metaphyseal osteopathy is where you get the bony proliferation. Can you picture it? X-ray on X-ray?
Yes.
Bony proliferation down the sides of all of the metacarpals, and sometimes like it can go right up the leg in severe cases, is often associated with lung tumors.
Oh, that's right. Murray's syndrome or some name like that.
Oh, I don't know. Have you heard of that, Penny?
Not by that name.
No. That might be the human equivalent, but I haven't heard that terminology. But it's something to do with the afferent nerve signaling being disrupted, which causes like proliferation of the bone. Does anybody know what the potential treatment for that is other than tumor removal? They
Like steroids. Or non-steroidals even? Because I don't think
try both.
Yeah.
I definitely tried both before I did what the listed treatment is.
Oh, what is it?
It's a vagotomy. Like cut the vagus nerve, which then alters the afferent nerve signaling and means that the bony proliferation, the signal to proliferate bone stops. But I just like the leap from there's bony changes here to let's cut a nerve in the chest is quite brave.
Yeah, wow.
I'm amazed that we got there. All right. Now we've got 5 minutes. Is there anything else anybody wanted to chat about?
Just look that up. Google knows, of course. Hypertrophic pulmonary osteoarthropathy.
Ooh.
Is what I'm thinking of.
Yeah, that's.
And I thought that was called Murray's disease or some name like that. The other question I was going to ask is the Cushingoid diabetic that's hard to regulate the diabetes because of ACTH surges. Is that a paraneoplastic syndrome?
Ooh, that is an excellent question. I've just gone on Google and I've lost you all. Sorry. That's a really good question because there's there are tumors that produce ACTH. And where I've seen that sort of written about, they talk about carcinoid tumors that are ACTH producing, not pituitary gland tumors. So I don't really know the answer to that but the pituitary gland is supposed to produce ACTH, so maybe it's not paraneoplastic. But excess ACTH is a big paraneoplastic problem. Not very common though.
Isn't there a lung tumor that does that? Like one of the lung, I think.
Yeah, in people, like small cell lung tumors will do that, but they're much more common in people than in dogs. But yes, definitely.
It's reported, so I know this because Dick Churcher wrote the paper and he was my residency supervisor. But there was a hepatic carcinoid reported in a dog, which was producing ACTH and causing Cushingoid signs. And when they took out the tumor, the signs resolved, and they did special stains and stuff on there and documented that it was ACTH producing.
Yeah, wow.
Yeah. But I think it's like single case reports only. It's not very common. But yeah, those Cushingoid dogs who don't have Cushing's, maybe worth looking into. All right. We might wrap up. I think we covered most of the things.
What about hypercalcemia?
Oh, that's a big one.
Too big?
We
Is
did
that
that.
not really own like rounds topic?
We actually did do hypercalcemia as its own endocrine topic.
Yeah.
So we didn't talk about it specifically as a paraneoplastic thing. So I don't want to go too deep also because we only have 3 minutes. What is the most common mechanism of hypercalcemia as a paraneoplastic syndrome?
PTHRP.
Excellent. Good. So most of the tumours that cause hypercalcemia will produce PTHRP. What does that do to calcium? Increases it. Good. So increases absorption of it in the gastrointestinal tract. And over time will increase resorption from the bone, what's that word? Osteoclastic activity, lysis, and calcium comes out. So if you did a radiograph of a patient with a neoplasia producing a whole heap of PTHRP, what would the bones look like?
Osteopenic? Osteopenic?
Osteopenic, exactly, yeah. Has to be quite chronic to get that effect. What cancers do we know that produce PTHRP?
Renal sac adenocarcinoma.
Good.
And is it T-cell lymphoma?
Yes, good.
Boxers.
Boxes, yeah. Yeah, fine, yeah. These are like often with the hypercalcemia, and Penny's probably going to say, don't be silly, but my clinical impression is when I see hypercalcemia in a dog, the lympho is usually just a little bit weird. Like it's not a standard multicentric. It's like in the liver or in the craniomediastinum as well, and it's just not following the rules very nicely. And then I go, oh, it's T-cell. Penny.
No, I agree. Like most of the weirder lymphomas are going to be T-cell. You can get hypercalcemia with B-cell lymphoma too, though. It's uncommon, but it does happen. But lymphoma and anal sac definitely the two most common neoplastic causes. And for T-cell lymphomas, we find that the ones that are in the cranial mediastinal region are more often hypercalcemic, but that can be tricky because a thymoma can also cause or a thymic carcinoma can also cause hypercalcemia. So just because it's hypercalcemic with a cranial mediastinal mass doesn't mean it's absolutely going to be lymphoma.
Say they said no to surgery, that's not an option, and you decided to give like a treatment, like a vincristine shot or something, would a drastic response to vincristine be predictive of lymphoma over thymoma, like as far as a diagnostic test goes?
With vincristine, yes. With prednisolone, no. Like you can definitely see, because prednisolone will treat the hypercalcemia too, right?
Yeah.
So often you're starting them on pred as well. But vincristine is a lot more lymphoma specific. It won't do anything really for a thymoma or a thymoma.
Okay, interesting. Cool. So lymphoma, anal gland adenocarcinoma. Any others?
Mammary.
Yeah, good. I've got thymoma as well, which Penny mentioned. Multiple myeloma.
Yeah, I thought that was it.
And in cats, what would be most common in cats as a cause of
Squamous cell carcinoma.
Good. Yeah. I have to say I haven't observed that clinically, but I don't see a lot of squamous cell carcinoma. But yeah, that's definitely what Edna just said. And then bronchiogenic adenocarcinoma as well. There you go. All right, we'll wrap up. We have musculoskeletal disorders next week. So, or no, fortnight, sorry. Can't remember what's in that chapter, but it sounds really boring and not up my alley. Does anyone else want to, does anyone else want to run it? We'll try and make it as medical as possible, but go from Edinger and then I'll just only tell you what you need to know. So we'll see you in 2 weeks' time. If anyone's got any cases or anything they want us to talk about, send them through and we can chat about them during rounds. Thank you, Penny.
Awesome.
Thank you.
Thanks.
Anna.
Bye, everyone.
Bye.
See ya.
Yeah, bye. Thank you, Anna.
Pleasure. Cheers, Jess. Bye.